by extracting the cannabinoids.
Well, I'm curious, do you think that administering the inhaled compound in a clinical setting, with that device that you just described, as opposed to the normal setting for inhaling, might bias the study?
Well, inhalers are part of clinical sort of paraphernalia, like with asthma and albuterol inhalers, of course.
Right.
Yeah. So I think that just as long as they know that they're either may get active or may get, nothing. Mm-hmm. It's certainly true that when patients are involved in cannabis clinical trials, all sorts of funny things happen, like you get paranoid reactions in the placebo group and things like that. But I think that we're of course, the studies that are done in Holland, they don't have those problems, so I think we're going to have to kind of do a little bit of international addition, but you're absolutely right. There are cultural, contextual factors that will have to be factored into it. But I think you can deliver it with a controlled fashion. And they even have a puff, as in the literature, there's a puff method, a certain number of inhales with a certain number of breaths, and they all have to do that. They have to practice that particular inhalation route. So, and then they test their blood to see if the levels are
It may decrease bias in one sense, but it may increase bias in another sense.
I see. Yes, that's true. We need large trials. A lot of questions. Okay, somebody had their hand up, or who was having their hand up for a while here? Okay.
I was only going to point out that there's many studies out there by the government where they've used Marinol, called it marijuana, and if you read down in the fine print, they said they use Marinol for concentration levels. In other words, it's complete charlatan work.
That's part of the confusion, misinformation is you terming it Marinol, make it sound, the company sells it as legal medicinal marijuana. That's one of their taglines on the internet. But there's 420 chemicals in cannabis, roughly, and one chemical in that, so I don't see how they're the same thing. Mr. Hyatt.
Yeah, I just got a study sent to me by Paul that came from somewhere. I think it came another one out of Spain or something that is a dronabinol whole plant comparison, and it's peer-reviewed and published in the reputable journal and all that kind of stuff. But it just came out. I just got it.
That was an Italian study in rats, looking at the pain, neuropathic pain model, and there was a difference between the whole extract versus a single cannabinoid. I mean, that's I think we've seen that more and more times. That'll show people that there is a medical difference between the two substances. That's important. Yeah.
So was the FDA approval of Marinol controversial, and how did that make it past the DEA? Marinol is not even Schedule 2, it's Schedule 3.
Correct.
How did that happen? It seems like an interesting story.
As Jonathan said, this is the peculiar drug. Everything's a little different with it, but originally it was in Schedule 2, and it was approved in '85 before we even knew the mechanism of action of THC. So that's something to think about. And they also it was a fast track procedure. It was something that it got to be approved under some kind of speed up process, kind of like the way the AIDS drugs, HIV antiretrovirals had been done in the past, if I'm not mistaken. I think that was ACT UP pressure. But it was one of those things where it was a lot of public pressure to get the FDA to do this faster. There were trials conducted, and then there was a study out of Haight-Ashbury Clinic to look and see if there was street-level use of abusability of Marinol going on in patient populations, and they didn't find any abuse going on. So they were able to downschedule it from 2 to 3. Originally it was in 2, but I think some of the pressure from the pharmaceutical companies, hey, we're not getting enough sales here. I'm being a little political economic in my analysis, but there was this was a conglomeration of pressures involved. '85 was also the same year that the rescheduling petition of cannabis was going through for the first time that citizens had filed in the 70s. And it finally got its day in court in '88, and the DEA judge heard it and recommended that cannabis be rescheduled to Schedule 2. So there was an idea that, well, we can preempt that process potentially by having a legal version of cannabis available for patients, and that's why it was sort of quickly sped up, I think.
If I could jump in, Sunil, Mark needs to leave. So why don't we end the kind of official defense part here?
Okay.
But by all means, why don't we stay until 12:30?
Okay.
Because I see that there's a lot of exciting people with questions and stuff like that.
Definitely. Thank you for coming. Joanna and Stitch were the first group to openly distribute cannabis, and were faced. Tell me, how many days in jail did you face for this crime of delivery?
She had one originally when we were busted, I had two, and she couldn't get granted because our judge wasn't available to go back to a convention in DC, and she got 2 more days for that. We got a lot of coverage on it. That's what we did for 6 months was coverage.
Oh.
As I understand it, Marinol is a synthetic copy of the THC. It's not exact, it doesn't come from the cannabis plant itself. It's a synthetic.
Let me stop you there. Actually, recently the Drug Enforcement Administration allowed for Marinol to be extracted directly from the cannabis supply that's grown at Mississippi. This is a new thing because they want to try to kind of go the extraction route now, just like GW Pharmaceuticals is going. Originally, for a long time, cannabis was, Marinol was synthesized in the lab and suspended in sesame seed oil. One stereoisomer of THC. There's actually 4 THCs in the cannabis plant. So this, just for those of you who know the chemistry, this is negative D THC, trans THC.
So is the current Marinol pill that you get,
It's still
not synthesized anymore, it's extracted?
I don't know if
Or is supplies made it out yet?
They're working it. Yeah, I don't know if it
Okay.
still applies. I think what's in Walgreens now is still the synthetic
the
sesame seed oil. Yeah, but it's coming. It's coming. So.
Well, at least sesame seed oil is what cardioprotective.
Yeah, but people try to smoke it, and that's not helping.
So, I'm not sure if I am remembering the numbers exactly right, but I think when you were talking about the delivery study, you said something like the clinic had served around 600 patients since opening, and 250 or 200 and something in the course of the 4 days.
Correct.
And then the doctors, there was something on the order of 100 doctors, patients had been seen in the history of the clinic, but something like 10 doctors.
20.
20.
Right.
So there's a discrepancy there, and if I'm thinking through this correctly, this implies a pretty poor continuity of care. I mean, it sounds like a lot high rate of doctor turnover for these patients. Has anybody looked?
Patient death too. Patients don't live as long as some patients. I hear, named things after dead patients. So I'm just something to think about. A lot of times patients don't, who are pretty
I'm
ill.
assuming patients get supplies and then move on to other supplying sources sometimes too, right?
That's possible too. Yeah.
They get it right.
There's other variables, but you're
But I'm just wondering if anybody's looked at whether continuity of care is poorer for patients receiving cannabinoid therapy, or if that's actually really typical in the American population and I just don't know it. And if your existing data set would be a way to look at continuity of care for, if there's information in there that we could use to look at that question.
Good question. I don't think my information has enough information on that because I only got medical records from one set of patients. The other set of patients, I have no information on there. I could ask them, but they're no longer involved in the study, but I don't have their information or anything. But it's certainly something to think about. I know that like in my access study, initial study, some patients, like the HIV patient I presented, had an authorization from his physician and was under their medical supervision, but then that doctor moved. I've heard that story a few times, and then they're really left. There's no referral. Okay, now I'm going to put you under the care of this doctor. It's just sort of your.
Are there clinics stop writing notes for patients anymore?
That's right. There's been some.
They've been federal effects.
The VA system doesn't allow physicians to authorize or anything. And then recently I heard of in Spokane, Eastern Washington, there's been a series of letters that were sent by the HMO Institute saying we don't really want our doctors doing this practice. Unfortunately, sometimes doctors will get those kinds of pressures and they'll force them to, even though no doctor has been prosecuted, lost their license doing this, there's still kind of since there's not a lot of information out there, there's these kind of problems. So that will affect continuity.
But Sunil, isn't, I mean, in truth though, this,
This is Dr. Kiyoshi Tapoja, I should mention.
this is, but in truth, you're gonna make me forget now what I was gonna say. In truth, this second clinic, per se, is functioning as a pharmacy.
As a
Okay.
botanic,
And so in terms of continuity of care, you have your, this is your medicine that you're going to be on for the next year or something. You go, you don't necessarily have to go back to there, you might find a way to grow your own afterwards. I mean, I can think of a lot of reasons where it doesn't define a continuity of care that you go here once and you might go someplace else to get that. I guess I'm not quite.
some patients did come from far away, so it's true. There's also a factor of more tenuous than the doctor's authorizations are facilities available to deliver the cannabis. So those things are up and down, like depending on the caprice of local law enforcement. So a lot of times patients will come through there, and then maybe something else will come up more locally. That's a good point. Thank you.
I wondered how long, because